everyone, welcome back to my channel. I know it's been a minute, but I'm back. I'm Sheila G, the PAC, and in today's video, I'm going to be talking about some of the most common skin lesions and rashes in infants and young children. Pediatric rashes can be very confusing and often concerning because so many of them look alike. So if you've ever looked at your child's skin and thought, what is this? Should I be concerned? You're definitely not alone. So in today's video, I'm going to be discussing some of the most common skin lesions and rashes in young children and what they are and what to do about them. But before getting started, of course, don't forget to like, comment, and subscribe to my channel for all things dermatology and skincare. Now let's go. Let's start with skin lesions and rashes that occur in newborns and infants, starting with erythema toxicum neonatorum, or ETN, which is a completely benign and very common skin eruption that occurs within the first 2 to 4 days of life. Now, this rash is a lot more common in full-term babies and quite rarely presents in premature babies. Now, this rash presents with scattered, red, patchy macules and small bumps that may develop pustules. This rash typically appears on the face, trunk, and extremities, but it spares the palms and the soles. Now, we don't actually know why this rash happens, but the good news is that it goes away completely on its own within a few hours to a few days. One important thing to remember is that this rash is not present at birth. That's important because it helps us to distinguish it from other potentially more serious skin conditions. Next are milious cysts, which are small epidermal cysts that are composed of trapped keratin or dead skin cells. These are extremely common on the face of newborns and typically resolve by 2 months of age. Now, these may also be seen in adolescents and adults, especially around the eyes, but are typically a lot more stubborn. These cysts are small and white in color, resembling little pearls on the skin. Again, in newborns, these just resolve on their own, whereas with adolescents and adults, more stubborn lesions can be either extracted or treated with topical retinoids like tretinoin. Then there's neonatal acne, which is also very common in infants. With neonatal acne, we see small red pustules with the presence of comedones, which are blackheads and whiteheads. Now, this condition can look a lot like that first one that we talked about, ETN, but with ETN, we don't see the presence of comedones, and that condition starts in about 2 to 4 days of life, whereas neonatal acne typically does not start until about 2 to 4 weeks of age. Neonatal acne is primarily seen on the cheeks, chin, and forehead, and is usually not widespread throughout the body. It's caused by maternal androgen hormones, which are passed to the baby in utero, and they stimulate the oil glands. This typically resolves at about 3 to 6 months of age. In more severe inflammatory forms of neonatal acne, however, we have to examine the baby for axillary or pubic hair and also abnormal findings of the genitalia, as that might suggest excessive androgen exposure. But for normal neonatal acne, we do not recommend the application of normal acne treatments, just gentle skincare. It will go away. Next, we have cradle cap, which is extremely common in infants. Cradle cap is an infantile form of seborrheic dermatitis, which we also may see in adults and adolescents. And it's an inflammatory condition driven by high sebaceous gland activity or oil production. And so we typically see it on the scalp, the face, including the T-zone area, behind the ears, the chest, and sometimes in the skin folds as well. Again, this is due to increased sebaceous gland activity from maternal androgens, and so with that high oil production, we also have the involvement of Malassezia yeast. So with cradle cap, we see these really inflamed, adherent, greasy yellow scales. Cradle cap may begin around 2 weeks of age and usually lasts for about 4 to 6 months. As previously mentioned, seborrheic dermatitis can affect adults and adolescents, but here I'm only referring to the infantile form of seborrheic dermatitis. As far as treatments, we do recommend using an emollient such as baby oil or mineral oil and a brush or a cradle cap comb to break up and remove those greasy scales before shampooing. In more severe cases or stubborn cases of cradle cap, sometimes we prescribe topical medications such as ketoconazole shampoo. Now let's talk about skin lesions and rashes in children. The most common skin condition seen in young children is atopic dermatitis or eczema. Atopic dermatitis is a chronic inflammatory skin condition that involves a dysfunctional skin barrier leading to dryness, inflammation, intense itching, and loss of protection against microbes. Now, I have a whole other video solely dedicated to atopic dermatitis because there's a lot to it, but simply put, those who have atopic dermatitis have a mutation of a gene that codes for filaggrin, which is responsible for maintaining that skin barrier function and keeping the skin cells healthy. This impairment of filaggrin leads to transepidermal water loss, immune dysregulation, and less protection against bacteria. About 85% of atopic dermatitis cases happen before age 5, and although it does tend to improve as the patient gets older, it can definitely follow into adulthood. Now, atopic dermatitis is part of something called the atopic triad, where we see patients often have asthma and/or environmental allergies along with their atopic dermatitis. In really young children and babies, atopic dermatitis tends to more often affect the face and the extensor surfaces like the elbows, whereas in older children, it's a lot more common to see it affect the flexural surfaces, such as the antecubital folds or behind the knees and the neck. Now, it's also commonly seen on the ankles, the hands, and the feet. During acute flares of atopic dermatitis, we may see intense redness with the development of small blisters and crusting on the skin. During subacute flares of seborrheic dermatitis, we may see scaling, bumps, and erosions. And then with chronic, long-standing areas of eczema or atopic dermatitis, we may see thickening of the skin, called lichenification, scaling, and pigmentary changes. There are many treatment options for those with atopic dermatitis, so again, check out my video if you want more detailed explanation on those. But essentially, the treatment involves really heavy moisturization, barrier protection, antihistamines, and anti-inflammatory medications. The next condition often goes along with atopic dermatitis, and that is pityriasis alba, which is the development of these vague, small, patchy areas of hypopigmentation where the skin looks lighter in color, and it's often on the face and the arms in children. Now, basically, this is due to some sort of dry skin condition, so a lot of patients have a history of eczema. So what can make this condition look more accentuated also is sun exposure, where the unaffected skin tends to tan, hence making the condition more obvious. Children often outgrow this skin condition, but treatment involves adequate and daily moisturization, adequate sun protection, and sometimes we may even use some sort of low-potency topical steroid like hydrocortisone to treat. Another common dry skin condition is keratosis pilaris, otherwise known as strawberry skin or chicken skin, and this often manifests on the back of the upper arms, sometimes the thighs, and it can affect other areas including the face. Now again, sometimes this can go along with other dry skin conditions like atopic dermatitis, but it's fairly common on its own. Now, with keratosis pilaris, there is follicular plugging, where the hair follicles get trapped with dead skin cells, leading to a rough and bumpy texture. And the skin can also appear pretty red and often dry. As far as treatment, we typically recommend some sort of chemical exfoliant, such as lactic acid. A common one that I recommend is amlactin lotion. Or you can use other chemical exfoliants, such as glycolic acid, to treat this. The next skin condition is a highly contagious superficial bacterial infection known as impetigo. Impetigo is caused by either group A streptococcus or Staphylococcus aureus bacteria, or a combination of both. And it occurs within about 12% of children and 5% of adults, so it's slightly more common in children. Now, about 1 to 10% of cases are caused by MRSA, so a culture and sensitivity should be done on those who have this condition to rule that out. Now, minor trauma typically predisposes a child to getting this infection, so think a bug bite or, again, a child that has really itchy eczema who's persistently scratching and breaks the skin barrier. Those who live in warm climates or play contact sports are also at higher risk. Now, impetigo presents as a cluster of small red bumps and pustules that start to erode and then develop this classic yellow honey-colored crust. Now, that honey-colored crust is quite characteristic of impetigo. There are bolus forms of impetigo where blistering may be involved, but that's kind of a separate conversation. Now, the treatment of impetigo really depends on the culture and sensitivity that is performed, but typically we prescribe topical antibiotics such as mupirocin ointments, and in other cases we may even add on oral antibiotic. Now let's talk about warts and molluscum contagiosum, both of which are viral skin infections that may be spread by direct contact and can spread to other areas of the skin. Molluscum contagiosum is caused by a DNA pox virus and appear as pink or flesh-colored, dome-shaped papules or bumps on the skin that have a central umbilication, which means a divot in the center of the lesion. Now, sometimes they can be itchy, and these can again spread by skin-to-skin contact, so we often see it in those who have eczema, swimmers, or those who share towels. Although molluscum contagiosum resolves on its own, this process can take a while. It can take months, if not years, and more can spread throughout that time period. When lesions of molluscum start to become very red and inflamed with surrounding scale, that's actually a good sign, because that means that the immune system is finally trying to attack the lesion and take it away. Treatment options for molluscum contagiosum include freezing them with liquid nitrogen, which is one of the more effective treatments, but this can be quite painful and hard to perform in children and often requires several sessions to get them gone. Other options include salicylic acid preparations, topical cantharidin or beetle juice, which can be applied in the office by a healthcare provider. There's also a newer prescription out called berdazimer, which is a nitric oxide releasing agent that can be quite effective, but it's brand new. For lesions on the face, sometimes we prescribe a low-potency topical retinoid like adapalene or a low-potency tretinoin. And then there's warts, aka verruca, which are extremely common in children, especially seen on the hands, the fingers, elbows, knees, and the feet. Warts are caused by the human papillomavirus, or HPV, specifically strains 1, 2, 3, 4, 27, 57, and 63. So just as with molluscum, warts are typically spread by others through skin-to-skin contact or other shared fomites like towels, shoes, or clothing. Now, minor trauma to the skin typically is what predisposes somebody to getting a wart. And so once that virus enters that broken skin, it starts to infect the epithelium. Now, most common warts are hyperkeratotic, meaning very rough and thick at the surface, and have small little black dots in the center, which represent thrombosed capillaries. But not all warts look the same. There are several variants of warts, including flat warts. There's anogenital warts, plantar warts, and of course, your common wart. For warts, the most effective treatment, again, is liquid nitrogen or cryotherapy, where we go in and freeze the warts, but these are notoriously stubborn. They require multiple sessions in most cases, especially the ones on the feet, as there's an extra layer of skin, so we gotta work harder. Other treatment options include over-the-counter salicylic acid preparations. There's a prescription cream called 5-fluorouracil, which is more of a chemotherapy topical agent that may be used. There's candida antigen, which can be injected directly into the warts, although that's painful, but that stimulates an immune response. And again, cantharidin, which is a topical agent that can be applied to them in the office. Now, viral exanthems or viral rashes are also extremely common in babies and children, but there's just too many to go through in this video. But generally speaking, when a child develops a viral infection, especially one that has fever or upper respiratory symptoms, it's not unusual for that child to develop some sort of rash, either during their illness or after recovery. But the type of rash that develops really depends on the virus itself, so we'll get into that another time. So there you have it, some of the most common skin lesions and rashes in babies and children. Thank you guys so much for watching, and please don't forget to like, comment, and subscribe to my channel for all things dermatology and skincare. I'll see you in the next one.